So welcome everyone. My name is Brian King. I'm Vice Chair for Child and Adolescent Psychiatry and Psychology here. And it's not entirely clear to me why I got the honor of introducing our speaker today, although I think it might have been someone who was clever and thought it would be cool if King could introduce DePrince. So in any case, we are very fortunate to have Dr. DePrince tonight. Dr. DePrince is Distinguished University Professor and also Vice Provost for Public Good, Strategy, and Research at the University of Denver. Many other titles as well, and I'll highlight a couple of those, but just by way of background, Dr. DePrince graduated with honors and distinction in psychology at Duke University, and then came to the University of Oregon in Eugene, where she did her master's and doctorate in psychology with a focus on trauma. And then went up to the University of Washington for an internship and also got experience in DBT. And then went to the University of Denver as an assistant professor, where she just rose through the ranks from assistant to associate to full professor to distinguished university professor. Along the way, she also served as department chair at the University of Denver, department chair for psychology. She's had a number of editorial roles, including currently the associate editor of the Journal of Trauma and Association, and previously for a decade was the editor of the APA's trauma book series, and edited 10 volumes during that time. Published 100 peer-reviewed publications, another 2 books that she has produced in addition to all the volumes, been funded for research for years and years. She really is, by every measure and criterion, the quadruple.
Yeah.
She's made, and she's received multiple awards. In fact, I think APA Division 56 needs to retire the outstanding service to trauma psychology because she just keeps getting it. So anyway, without any, and one last thing, for which we are enormously happy and proud, is that among Dr. DePrince's students includes our own Dr. Ann Chu, who is wonderful too. So without any further ado, I am really, as I said, honored to welcome Dr. DePrince here, and thank you so much for making it interesting.
Wonderful introduction from the King. I am used to, when I am in spaces with Dr. Chu, just introducing myself as the other Anne. So that was very wonderful. Thank you. I'm really excited to have a chance to spend some time with you today to think about multidisciplinary solutions for systemic problems facing the family and children with whom lots of you work. And Dr. King, noted my undergraduate roots. I was a history major along with a psychology major. And so contextualizing how I think about my work in a sort of current as well as historical context has always been important to me. And I find myself lately very aware of the change that we've seen over, say, the last 50 years, that there has been really a transformational sort of shift in public awareness and scientific understanding of childhood trauma and family violence, and the impact that those kinds of traumas have on individuals, families, communities. And this is thanks to a lot of hard work from teams around the country, and including work happening here at UCSF. After all, you all have led the way in advancing evidence-based interventions for parents and children who are dealing with systemic health inequities, psychopathology. You've studied how to deliver care in multiple kinds of settings, from community health to through pediatric primary care. You've been at the fore of implementation and dissemination science. You've shown how it is possible to adapt medical and service settings to really meet the needs of the children and families we serve, while also training the next generation, who looks like is in the room today. And this is all very, very exciting and something to be proud of. But I guess that you, like me, you've also noticed that this period of transformation, this incredible work you're doing, it's also happening in the context of a moment in time when child abuse and family violence remain all too common. And we see that communities really continue to struggle to meet the interconnected service needs that arise from interpersonal traumas like child abuse and family violence. And this probably is the case in your work as well as mine. My work keeps pointing to the fact that the consequences of child abuse and family trauma, particularly things like intimate partner abuse, they rarely fall to any one discipline. And so while we have tried to have disciplinary solutions, I find that that's difficult to do. If you take, for example, access to healthcare or health consequences of trauma, there are obvious ways that child abuse and family violence are tangled up with health and health delivery systems. Whether it's thinking about the costs of emergency care for those very preventable kinds of traumas, through to long-term respiratory correlates of family violence and child abuse. There are connections to education. On my own team back in the day when Dr. Chu wasn't yet Dr. Chu, we were studying some of the executive function correlates of child abuse and family violence, finding that witnessing family violence had serious consequences for executive function, that children who were exposed to that kind of trauma performed significantly worse on batteries of executive function, including working memory, than children who had been exposed to other kinds of traumas, or children who had never experienced any trauma. And we know that those early pinnings of the development and use of your executive function system interacts with things like your success in school, but not just your success in school, the success of the teacher in your classroom trying to manage your behavior, the success of the student next to you. And so it quickly became clear that it's also not just about school, that these issues are tangled up with economic causes and antecedents. That we see on our team, that parents dealing with intimate partner abuse, that they are at higher risk of re-victimization if they're unemployed when we first meet them. So in one study, we found that 6 months later, the women who were unemployed after an incident of domestic violence was reported to law enforcement, they were more likely to be severely re-victimized. And things go in the other direction too. We know that abusive partners target and sabotage the career success of the moms of the children you're serving. And so we see this sort of, this ripple out of ways that the causes and consequences of family violence keep building and building in terms of the burden that children and families are bearing. I think about some of our work here on food and housing insecurity. It's hard to do therapy when you're hungry. And yet we find that things like intimate partner abuse is linked with executive function problems, just like we saw with children. And in turn, those executive function difficulties, a year after an incident was reported to law enforcement, a year later, that executive function difficulty was linked with having a tougher time having food on the table and a roof over your head. So we're talking about trauma insults that affect a real breadth of behaviors and opportunities. And certainly we see on my team, and I'm guessing you do on yours, that trauma makes it harder to access a host of resources at a time when your family needs many resources. Some of those social service, often legal resources, in addition to things like supports for education and career and some of the other issues I've been chatting about so far. So with that kind of complicated web in mind, I wanted to talk with you today about one strategy for trying to meet the interconnected needs of the families and children we serve through the development of multidisciplinary teams, or MDTs. Now, you all are probably working on lots of multidisciplinary teams connected to the care you offer or the research you do. But I wanted to draw your attention today to a version of MDTs that also has a historical context. So I study intimate violence in its many forms. And what we've seen in that community-based service world tied to child abuse, domestic violence, sexual assault, is a sort of outsized impact, I think, of a very important piece of legislation, the Violence Against Women Act, or VAWA, that was passed in 1994. It was passed in the 1900s. It was like a million years ago. But that act has been very important for funding community agencies across the country to provide a host of services for victims and survivors, often of gender-based violence. And what happened in that VAWA legislation, there was a lot of good and a lot of complicated outcomes from that legislation. But one of the things that VAWA did was started requiring collaboration between criminal legal entities and community-based agencies in order to access their funds. And this started out somewhat specific to sexual assault and domestic violence, but over time, I think what we have seen in the community-based victim advocacy world is that this pairing of criminal legal and community-based providers and assuming those services go together has become more of the norm. And what, instead of calling them MDTs, in the world I hang out in with community partners, they call them community coordinated responses, or CCRs. So when you hear CCR, people are typically meaning, it's a shorthand for, there's some criminal justice or criminal legal entity, like a prosecutor's office, the police department, probation, one of those entities involved collaborating with a community agency. And so VAWA sort of set in motion a lot of CCR responses to human trafficking, particularly sex trafficking, violence, domestic violence, sexual assault. And I never set out to study community coordinated responses. I'm a clinical psychologist. I'm trained in what you do in a room individually with a client. But I wanted to do work that, I used to use a shorthand of, I wanted to do work that mattered. And what I meant by that, I realized over time, was I wanted to do research that was policy and practice ready. And so I started collaborating with community partners to try to satisfy the scientific questions I wanted to answer in a way that quickly got to policy and practice. And what happened was a lot of agencies wanted to know if these multidisciplinary teams, these CCRs they were running, were they working? They were popping up new kinds of ways of coordinating, not without tensions between different partners in the room and trying to think, is this really trauma-informed and survivor-centered? And so I ended up going down a 20-year rabbit hole, looking at CCRs and asking a few key questions. What's the evidence of both benefits as well as costs of this kind of collaboration, particularly for families who are very, very system involved, where accessing care that somehow connects to legal systems may be complicated. So what are the benefits and costs? What does it take to build CCRs? If the government is expecting communities to be able to set up these kind of multi-pronged collaborations, what really goes into that? What does it take to evolve them? It's nice to set something up, but can you keep it? What does it take to sustain them? And then how can we measure their impact in a terrifically imperfect world where there is a lot of staffing change, a lot of stresses and strains? You might have noticed some policy changes happening in the last year or so that also have really made the world unstable for a lot of agencies trying to provide these sort of services. And so I want to give you a window into how our team has tried to answer some of these questions. starting with just what's the evidence? Is this a good idea? Was this something really smart that came out of that VAWA back in the 1900s, in 1994? What are the benefits and costs? And we started doing this work with community coordinated responses with a particular project in Denver called the Triage Project. And this was one of the early VAWA funded programs back in the day, where Denver, through the district attorney's office, set up this triage review team that involved folks from the police department, the prosecutor's office, and several community-based agencies, as well as representatives from probation and a few other criminal legal offices. And what they were doing was every day they would get together in a room. This was pre-COVID, so it was a real room where they would come over to a building and talk through all the incident reports that had come in the last 24 hours for domestic violence cases. And they would pick a lead agency from the community-based side, someone who either did legal advocacy after domestic violence or counseling or shelter services. And as they were staffing the case, they would try to figure out, is there a kid involved who needs counseling? Do they need safe housing? And based on what they understood about the case at that moment in time, that community-based agency would reach out to the victim or survivor and say, we got your name through the police department. We understand there was an incident. We want to offer you these services. We want you to know we're here. So we were testing essentially a phone call. What is the impact of a phone call to try to right size and connect people with services very quickly? These were all women. And the program, when we came on the scene, it had been around for a little bit, but they didn't have a lot of capacity yet. So we had an ethical moment in time where we could talk our collaborators into randomizing since they had limited capacity, doing a virtual flip of the coin to say, do folks get this outreach from a community-based agency after this coordination, or do they get usual care in Denver, which was you might receive a list of referrals by email or mail, or a victim advocate from the police department might say, sounds like you could use some help from Safe House, here's their number. And so after this reports came in, there was this multidisciplinary review and folks were randomized to what I'll call outreach or referral conditions. And what we saw over a subsequent year, we ran behind the scenes, sending letters out to folks who were identified as victims in police reports, inviting them to a women's health study. Once they came into our research offices, we did a full consent to say, we really got your name through the police reports. The study is actually about domestic violence. Of 326 women who participated in the study, there was one woman who, upon learning about the study, didn't want to participate, but folks were very willing to engage with the study. And we tracked a number of outcomes. And so what I'm showing you here is PTSD symptom severity from a first interview shortly after the domestic violence incident, 6 months later, and then a year later. And that outreach condition is the solid line. And what you'll notice is that everyone showed gains from the baseline to 6 months, which isn't surprising. It fits a pattern we often see with PTSD symptoms, as you well know. But the outreach group held on to those gains a year out, while the folks in the referral condition, their symptoms were starting to climb back up. We saw some other gains for women who got that outreach phone call. We looked at stay-leave decision-making, and we found that women who were in the outreach condition were more likely to have left or be thinking about leaving the abusive partner. We found that the two groups, they accessed services or got to the same number of agencies. So they found their way in Denver to agencies that serve victims and survivors of intimate partner abuse. But interestingly, the folks in the outreach condition, even though they were passing through the same doors, they perceived the services as much more helpful than folks in the referral condition. And we saw along the way, there was a lot of trepidation from the prosecutor's office, from the DA's office at the time of what's going to happen to my case if there's victim advocates running around kind of interfering from the community-based side. And so there was some tension. Again, these aren't easy collaborations to put people who are part of various adversarial and sometimes collaborative systems together and say, ready, set, go, collaborate. But we were able to provide them evidence that at the end of the day, that outreach and referral condition, there were no differences in the likelihood that cases resulted in a guilty verdict, in likelihood that cases were filed and eventually successfully prosecuted or pled. There were a few other women, you're like, hey, you went from 2 groups to 4. I did, you're exactly right. There were a few other groups of people that we ended up tracking. Some were folks who refused to talk to the victim advocates in the police department at all. Those are in red for D, for they declined. And the folks in yellow were people that were never reached by the police department. And so we pulled them into some of these analyses, including looking at how the final cases turned out. Now, when our partners and I sat down to initially design this study, I was interested in PTSD and depression and fear, and I should have said depression and fear showed that same pattern of gains that were maintained a year out for the outreach condition, but not for the, not for the other conditions, for the referral condition. But at the start, my partners were like, this intervention is going to change the world. People are going to be healthier. They're going to be safer. There's going to be greater accountability. And I drank the Kool-Aid. I was like, amen. We're making the world a safer place because of this intervention. I'm so excited to do this research. And then at the end, it turned out we had not made the world a safer place. That when you looked at re-victimization over the subsequent year, there was no difference among the groups, whether you were in that never reached declined group or you got the referral condition or outreach. And so there was some real stepping back that we had to do as a team to think about what did it mean that our assumption about the world was if we direct services at victims and survivors, that they will be safer without directing the action at people who are perpetrating and causing harm. And so it was a moment of realizing what is really possible in terms of community coordinated responses, depending on who they are wrapping services around. And this sort of very quick and slippery slope there is to assuming some sort of agency for victims and survivors to essentially prevent their own abuse. And so we'll keep coming back to this as we think about CCRs, which are often, I have spent my career doing survivor-centered kinds of studies. And so I say this with a lot of humility and wondering, when am I going to quit my day job and start working with people causing harm? Because lots of times we're trying to fix things on the survivor side. And I'm not sure what to do with that or where to put that, but want to flag it here. We also saw evidence that the criminal legal system, while there were gains from this outreach condition and so forth, it won't shock you to learn that it's not necessarily a system that offers the kinds of solutions that everybody wants. We saw a lot of women who, when new incidents of domestic violence happened, they didn't call the police. And a lot of the reasoning they offered for us was for those decisions was they were generally dissatisfied with the system. They weren't sure whether new incidents of domestic violence were serious enough to call the police. And this, I think it was about more than a third of people said I wasn't sure if it was serious enough. And have you ever been in a study where you get confused partway through after talking with people? I was like, what is serious enough to call the police? And I remember calling my friend at the DA's office, and I was like, when should people call the police? I'm getting really confused about this. And we had this whole conversation about what is serious enough to call the police. And certainly victim advocates would say, obviously, survivors know best. They understand the dynamics of abuse. They're the ones to make that judgment. And yet we were seeing this dissatisfaction with the system combined with sort of a sense of, I don't know when or if this system really is available to me or is a good use of my effort. Folks were also, a quarter of folks didn't call the police again, specifically because of concerns about negative consequences on their children. And so lots of times when we're talking about intimate partner abuse, again, we're talking about family violence. where children are witnessing. And so that triage work opened up a lot of questions for us about what does work in CCRs for children and families. There do seem to be some upsides of these kinds of collaborations, like if a phone call can be linked with decreases in symptoms, I'm all for that phone call, but it's not necessarily, it's probably a more complex story. So we went on with a colleague of mine, Julia Dimitrieva, to do some work with folks putting together a community coordinated response to respond to child abuse allegations. So we caught another moment in time where there was a group involving medical providers from Denver Health, along with the police department, social services, and some few other agencies who were in the process of co-locating. And as a part of co-locating in a single building, they were starting to shift their practice to something that looked more like a multidisciplinary team. So we had this moment in time where we were able to come in and work with them to try to understand what were the benefits to them and to their processes and to the children they were serving of this co-location, of this collaboration. And so our goal in this project was to try to understand the impact of these co-located responses, but this was not a case where we could randomize cases. And so what we ended up doing was looking at this multidisciplinary team investigation after child abuse and neglect incidents were reported. And we compared nearly 1,300 children who got the multidisciplinary team response to matched cases of another 1,300 cases where there was not that co-location multidisciplinary response. And what we saw really surprised our partners. They thought that co-locating and working together was going to make everything like chop chop a little bit faster. It didn't. It in fact slowed things down. They took on average almost 2 days longer in their investigation period, which if you've met somebody working on these teams or you are someone working on these teams, 2 days is a long time with a big caseload. We saw also that they had more documented contacts. We were down in their administrative files, looking at their activities and the things that they were logging. They had more documented contacts if the case was seen through this new co-located multidisciplinary team. And cases were 3 times more likely to result in substantiated allegations with the multidisciplinary team. And the kids in those cases were 2 times more likely to be placed in kinship care within the first 90 days. There was no difference in the likelihood of being in non-kin out-of-home placements. And so we looked at these findings and we were puzzled, as perhaps you are. Is it a good or a bad outcome to see more substantiation? Is it a good or a bad outcome to see that investigations are taking longer? Qualitatively, when we talked with our partners, it sounded like things were taking longer because they were being more thorough. And that is certainly something that we hoped. And we saw in another study, to bookend this with a very different period of development, we looked at a older adult intervention, a multidisciplinary team that brought together similar kinds of agencies, but it was a larger collaborative. And in that instance, we were able to randomize cases to this new CCR or treatment as usual in Denver at the time. And in that older adult CCR, we saw similar things where part of what was shifting was how our partners were doing their practice. They were more likely to be communicating about cases. They were more likely to hear about cases before they were presented to the MDT because people were actually consulting a little bit more. And there was some optimistic findings for re-victimization. The cases that got this coordinated response were less likely to have a reoccurrence of a maltreatment allegation in the next month as well as the next year. It also looked a little like our triage findings where there seemed to be different sorts of service engagement. So we started to see this picture of how practice is changing for our partners around the table. Some things seem to be changing for the clients being served, older adults, children, regular adults. But for the working together study, to try to understand a little bit more about how to make sense of whether outcomes are good or bad, positive or negative, we talked with some of the caregivers involved in those investigations. And we brought an institutional betrayal framework to those interviews. So institutional betrayal is a concept that sort of grew out of betrayal trauma theory. Betrayal trauma theory talks a lot about the importance of the victim-offender relationship, and especially dependence in that relationship, for understanding psychological and health and other kinds of outcomes after trauma. And institutional betrayal recognizes that for many of the children and families we serve, they are dependent on the systems they are interacting with. And those systems have outsized power in affecting a lot of things about people's lives, from service access to freedom, to access to their children. So you could imagine that such concerns about dependence in the system are particularly salient for caregivers going through an investigation. So we talked with about 32 caregivers, about half of whom were identified in the case as the parent who the allegation was against, and half who were not. And we asked them about their experiences with this multidisciplinary team. What was it like going through the case? We asked questions to get at their understanding of their role in an investigation process. We asked about their experience sort of from start to finish of the investigation process. And we looked at those data through the lens of what has emerged in the institutional betrayal literature recently about things that seem to predict worse outcomes for survivors, things where institutions make mistakes, and there are additional burdens and harms on survivors. Things like exclusion, discrimination, invalidating survivors, knowing something but not taking action about it. And we found instances among caregivers for all of these indicators of a system not working well yet for the families that it was trying to serve, that parents were feeling excluded and a lack of agency, not knowing what their role in the investigation process was, feeling like it was something done to them and their children rather than with them. Lots of perceptions of discrimination, a sense that if they were a certain skin color or a certain economic background, that the case might have gone differently. Lots of invalidation of their concerns. Often that invalidation overlapped with sort of poor communication and just feeling not listened to. And then a real concern around inaction of the system. And to be fair, we also heard positive things. So about 1 in 4 of the caregivers we talked about really having a sense of agency and ownership and feeling like a part of the process. So there are counterfactuals to all of these. And yet these themes of things about how uniquely challenging it is to be dependent on a system that it causes these kinds of experiences. We found throughout, we didn't ask people explicitly about communication, but that came up over and over again, that there were just some basic things about communicating with families to explain what was happening that they were urgently encouraging. And that echoed to other work we've done where we have looked at people's perceptions of things like the criminal justice process after sexual assault. Time and again, there are simple things that we can be doing as providers to clearly communicate with folks, even if the communication is there's no update, or even if the communication is this part's out of your control. I want you to understand what part of the system you have agency or not. That communication is really part and parcel for folks of feeling like they're being treated with respect and dignity. That may not be an easy system, but it is at least a system that is respecting them. And so that communication piece came up over and over again, really as key to keeping doors open, not just for collaboration of the team amongst themselves, but really we started getting a sense of the importance of collaboration with the survivors and clients that those teams were serving, and the importance of engagement with one part of the system having a potential impact on the rest of the system. So if you have a caseworker who doesn't call you back, clients aren't distinguishing that caseworker from the whole rest of the team. It's sort of like we rise and fall together, even though as I sit in a lot of these multidisciplinary teams, everybody has a very strong sense of like, this is my part, this is your part, like we're separate. That's not children and families' experiences of things. We saw that these kinds of issues of how the best of our practice can keep doors open for people to make more informed choices in a study of sexual assault and a coordinated response in Denver, where we were looking at some issues around how people respond to disclosures of sexual assault. And I often joke with folks that there are only 2 positive ways to respond to disclosure and 1 million negative ways that you could screw up a response to disclosure, according to a measure called the Social Reactions Questionnaire. And so some of the positive things that victims and survivors tell us that they get in responses to disclosure have to do with emotional support, tangible aid, but there's a lot of negative things. And a lot of the literature has shown it's the negative pieces that predict things about, say, post-traumatic stress disorder and other sorts of symptoms. Well, what we found in this study was that how community-based providers, so folks in rape crisis centers, support services, how they responded was linked with the likelihood that folks had reported to law enforcement. And of course, sexual assault is one of the most underreported crimes to law enforcement. And so we saw this correlation at the first interview we had with folks, and we wondered whether it was once you're in the legal system, it's a really hard system as a sexual assault survivor. So perhaps it's the case that community-based providers start providing you a lot of tangible help because you're swimming upstream in a difficult system. So we weren't sure the causality of that link. But it turned out that over the next year, folks who had a better initial experience with a community-based provider were more likely to make a delayed report to law enforcement. So even for a system that is very difficult to navigate, one member of the team, strong interactions, helpful, practical interactions with community-based providers literally kept doors open for folks to make a different decision down the road around reporting. So this body of work has pointed us towards, really building an understanding of ways that these kinds of coordinated responses can have a positive impact in the lives and well-being of survivors and their families. Some drawbacks to weigh, some things to consider. And the federal government kind of doesn't care what we have to say about how great these responses are, these multidisciplinary teams. They're calling for them anyway. So if you look at calls to this, well, there aren't as many these days, but from the Department of Justice for VAWA funding, they still have the CCR part built in. And so what does it take? What are we asking of communities? We've tried to understand that too, because we would be around tables like CARET, the Child Abuse Response Improvement Team, the Working Together study. Around those tables, we were seeing conversations, we were seeing some of what it looked like to try to negotiate and evolve a collective response, and really wanted to try to capture that. So we had this cool opportunity a few years ago when the Obama administration had issued a now infamous Dear Colleague letter where they said to universities and law enforcement, you got to get your act together and figure out when you're both investigating campus sexual assault allegations, you have to have a way of coordinating with one another. And it sort of set campuses on notice that they needed to build memos of understanding, MOUs, between law enforcement and things like a Title IX office on a college campus. And in Denver, this brought a whole bunch of actors together who were involved in sexual assault prevention and response, community-based agencies, law enforcement. Instead of just doing a small MOU, it was like a city affair to figure out how are we all going to collaborate together. So they had one job, right? Build an MOU to understand how you're going to coordinate your responses, because a Title IX process is a civil rights related process. and a law enforcement investigation is a criminal legal investigation. Those are two very different systems. They don't even talk the same language. One talks about respondents and complainants, and the other talks about victims and perpetrators. And so you could imagine they have different timelines, different ethical responsibilities. And so you could imagine as a survivor, you might end up caught between these two systems. So that dear colleague letter was really well-founded to say, get it together, figure out how you're going to collaborate. So as they were figuring out how they were going to collaborate, we got their permission to be a bit of a fly on the wall. We observed their regular meetings and took rapid notes on every utterance happening in the meetings. We did interviews with different stakeholders in the team and tried to really understand from the first meeting, when you first decided to try to build a way to collaborate through to the end, what happened? And what we found was we and all of the people who were coming to these meetings, they expected they would primarily be figuring out new procedures of how they're going to work together. But it turned out in those group meetings, we heard them talk a lot about current procedures. What are they each doing now? Because it turned out they had no idea really. Well, not no idea, that's not fair. They didn't know a lot of one another's procedures. There was suddenly a lot of problem solving. Once they were in a room together, they were not only trying to solve problems about co-investigations, but also other problems that were just generally coming up in cases that overlapped. There was a lot of consultation. There was a lot of information sharing. Here's where to get this resource for a victim. Here's a new piece of legislation that might affect us. And they did indeed have some conversations about policy change and also about their process themselves. So partway through the study, I'm a community engaged researcher. So part of my practice is to go back to the groups I'm working with to say, here's what we're starting to see. And so I teed up the worst slide visually that I've ever presented in my life. But I entitled it and explained to them, this is the why you're tired slide. Because when we looked at these things that they were doing in meetings, this is what their process was. It was a wild ride. They were all over the place because they were trying to build the proverbial boat while they were sailing it. And building a new procedure didn't have time to wait for some other pressure, a policy change or a funding change. And so this was not a linear process. And we learned to say the least, and we learned from them that there's really a lot that it takes, particularly strong leadership and facilitation when you're trying to build one of these CCRs from the ground up. And that our grants and our grant funding kind of approaches don't always recognize the real relational time and commitment that it takes. And a lot of folks were, for supervisors in the room, a lot of folks were saying their supervisors back at their home agencies really didn't understand the importance of them showing up and having face time at these meetings, but that relationship building was actually so essential to what they were doing. Unlike the campus sexual assault world where they had one job, build an MOU. I don't think they ever finished the MOU, but they did a lot of really good work together. They had one goal and it got all topsy-turvy. We've been part of other CCRs where they didn't even have that single driving goal of bringing people in the room. And I wanted to highlight here a project we've done with a group called LINK, the Legal Information Network of Colorado, who's part of an agency called the Rocky Mountain Victim Law Center. And they got together a group of people to go after some Office for Victims of Crime funding a million years ago. And that funding was to build wraparound legal services. So they recognized that after child abuse, intimate partner cases, there's a lot of needs that we automatically think about, like psychological needs, safe housing, but there are a ton of legal needs that might be in the civil system, like getting a divorce, fighting for custody of your child, that might be in the criminal system, trying to navigate and understand the very complicated criminal legal world out there. And so this group came together and they were going to go after this funding to build wraparound legal services in Denver. And I got invited because they were required to have a researcher. Like no one would have invited me except that they had to have someone say, I'll be your researcher. So I was like, I'm game, I'll be your researcher. And we got the funding. And then it was hilarious because we were back around the same conference table. And we're like, what are we going to do with the money now? What is our solution to wraparound legal services? And it was like the best projective test ever, though projective tests don't have a great evidence base, but it was the best projective test ever, because whatever discipline you were from, you thought that was the answer to how do we build wraparound legal services. The lawyers wanted more lawyers, the social workers wanted more social workers. And I was like, we need more research. So we all have a brand that we bring to these collaborations. But I kind of won because the grant required us to do a needs assessment in order to figure out really what should these dollars be invested in. And in a way, that's pretty fabulous. They gave us time and money to say, what kind of multidisciplinary team, CCR, are we building towards to improve legal services? So we did this cool 3-phase needs assessment. And after a lot of in Denver, we thought we were really good at collaboration. We have all these MDTs already. We were one of the first sites for VAWA funding. There was we're doing great. And there's a lot of great stuff happening in Denver, but that is not what this needs assessment revealed. Folks really thought we're going to hear we need more lawyers. We're going to hear about an isolated need over here. And what we heard was a big mess, that there was inadequate information about legal issues, resources, funding, lack of system coordination. And there were things that we couldn't solve as a steering committee. So for instance, one of the things that survivors will tell you is that the criminal and civil legal systems, like the judges and the magistrates, they don't talk to one another. And if you're not a lawyer or you're not working in those systems, it doesn't make any sense at all why two judges wouldn't pick up the phone and talk to one another about the same defendants or complainants or whatever language they're using. But they don't. And people didn't understand that, and was affecting victims and survivors' experiences in the system, ability to make informed decisions. It was affecting their empowerment. And so we took that needs assessment, and Link ended up developing this very cool program that we've been lucky to be part of, then helping to evolve over the last decade. So that's where I want to shift a little attention. Once a group figures out what they're going to do, how do they build and evolve that practice? And what we've learned is that the research world is not necessarily built to respond to what they need, the kind of data they need in order to test and understand some of these sorts of interventions. And so we've had to invest time in developing new measures, in this case, measures of barriers to legal services for crime victims of child abuse, domestic violence. We've had to learn a lot about how do you keep people engaged, not for a study here or there or a few time points, but over years as this project has evolved. How do you keep them engaged, make them feel like data matters and is being used so that they're going to keep assisting you with acquiring a really long view of the kind of change that might be possible with these community coordinated responses. So we've been able in this study to take that long view. From 2015 until November of last year, we were gathering monthly data about the barriers facing victims of crime in and around Denver and ultimately across the state. And we found ways to get that sort of perspective over time of how things were, a monthly sort of measuring, monitoring approach, and then a deeper dive with complementary surveys that we would do once a year. And this long view and this sort of the results, the return on investment of developing those measures, developing relationships, what has been that we've been really well positioned to help our partners use evidence on the turn of a dime to understand what's happening in their community and advocate for resources. So what you're looking at here is some images of a particular barrier to legal services that wasn't really on anyone's map. We weren't really monitoring it very closely. It came up in some interviews, so we had an item about it. Clients don't have access to technology they need to get legal information. It came up, so we were monitoring it, no big deal. COVID happens. Courtrooms start transitioning to online dockets, virtual dockets. It turns out if your abuser has bashed your phone or you don't have fast enough broadband, suddenly you have tech barriers to accessing the legal supports that you need. And so we were able to help our partners with data from their communities get ahead of those sort of issues. And so this is a form of action research that we do on our team, where we try to have data collection mechanisms that allow us to do really rapid feedback to steering committees. And we're starting to apply that now in a new project, looking at a problem-solving court for youth who've been picked up on handgun firearm possession charges. And our community has developed a 7-session curriculum that they are hopeful will help young people learn some new skills, will impact recidivism, and we're there along the way while they're building this intervention to be using data in this sort of rapid return style. And I would mention too, that some of these interventions over time, the sort of relationships we're building, you're not always sure when the investment will pay off for your partners, for the work you're doing, for the science you're doing. Back in that triage project that I mentioned to you, incidentally, we had included a measure of head injuries because we were starting to wonder if we were missing head injuries in that population. It turned out we really were, that more than 1 in 2 of the women who had incidents reported to law enforcement had a lifetime likely mild traumatic brain injury, not even counting injuries arising from strangulation. And so that early work led us to chase down some other studies around brain injury frequency and impact in this population, and has led to a new randomized controlled trial where we're looking at adding brain injury support services early in the victim assistance unit response, so that folks are getting information about brain injury early on. So more to follow on whether that expansion of an existing community coordinated response is useful. So part of the story of us trying to understand these multidisciplinary solutions has been the problem of trying to deal with these really, to call them imperfect data is generous. You might have a staff member who fills out a survey once a year when you're doing monthly data collection. You might have staff moving to different agencies, so they're still getting your survey, but they're wearing different hats, or they've left the field entirely, as we saw a lot of coming out of COVID. And so we've had to spend some time thinking about how do we handle these kind of data where repeated measures and within subject designs are like a bridge way too far for this kind of monitoring that we were trying to do. And so it's also been a really creative time on our team, trying to think about how we can borrow from public health and more surveillance models to understand and compare patterns of data over time. And what we're seeing, of course, in those patterns of data, like the COVID example, are some really concerning shifts for the children and the families that our partners are trying to serve. So here you're looking at the barrier of clients being afraid to access the legal services they need because they're afraid that their legal status or someone that they love will be impacted. And we have seen a significant, using public health interrupted time series approach, a significant shift since January of last year in that barrier, not surprisingly. But don't underestimate what it is to say that as an independent researcher versus community agencies saying that. And so they're feeding us the data that we are able to feed back and figure out whose voice do we amplify to tell this story to different policymakers or to try to have an impact, a positive impact for families. So it might be obvious from newspaper headlines that this is the case. There is something different sometimes in how we can advocate for those stories. We've seen similarly things like we've had dramatic drops in funding for victim services, these kind of community-based services in Colorado. And we're seeing that corresponding drops in access to social support and difficulty getting needs met on time. So that really brings me to what I wanted to close with is really pointing to your role, our role as professionals in telling the story of collaborative solutions for policy and practice change. And these stories aren't perfect stories. They aren't panaceas that if we just get the right people around the table, XYZ will change. But we can make data-informed stories about what we think will work best. And use data to argue for changes that can improve the lives of children and families. And I have become a big advocate for really thinking about ourselves as public scholars. What audiences can you persuade? What writing and external facing opportunities can you take on, whether it's op-eds or white papers or testifying in front of your legislature or your city council to get your data in front of decision makers, because you have a really important voice in making a difference in the individual clients with whom you're working, but at this larger policy and practice level. And what I have learned is that if you don't tell the story, someone else will. So if you don't tell the story of your data and what it says about what we need for policy and practice, what sane and rational and evidence-based policy is in this country, somebody else will. And so when I think about what story I want to tell, it is certainly a story where the last 50 years have been a series of progress and setbacks, but a fervent belief and a fervent optimism that change is possible, that we are able to do something with the science and the practice we do to build a better world. So invite you to be part of that. And thank you for listening. And we can do a few questions. I didn't take right till 1 o'clock. Any questions? Yeah.
It was early on in your talk, your paper on kids witnessing domestic violence. How old were those?
Those are school-age children?
The elementary school?
Yeah.
Okay.
Yeah.
Sure. I wasn't ready to hear you say back in the 1900s, referring to the 90s.
I got that from Nate Forgetsy, but I think it's so clever.
I was really struck by talking about rising and falling together as an institution, and if you're talking about different systems than the ones that we work in, and really felt like something that applies greatly to our healthcare system, and how when we aren't all acting effectively as a team, that can the whole experience brought down. So anyways, I don't know if there's any lessons that maybe you've thought about for our healthcare system that could take from some of your work or what you found.
Yeah, well, I think
Multidisciplinary teams.
it also Rise and Fall as a team, and that institutional perspective I share, that you don't know what doors you're opening for other teams, where folks have a good experience with you and they may be more likely to seek other care. And so good work. Last word.
I was just gonna thank you for such an incredibly overarching presentation. I mean, my head is spinning a little bit too, just with like all the different studies and multidisciplinary teams. So I don't think it has settled enough to form a question, but just thank you so much for this really incredible breadth of work that you've done and that you shared with us in such a short amount of time. Really masterful.
Yeah, for sure.
Mm-hmm. Here.